Hi, good morning, everybody. And hopefully you can listen, you can hear me. All right. Thank you very much. And thank you, Dr. Ida. And it was a quite interesting presentation just now. All right. So moving from a psychiatric disorder, we now move to what we call a muscle strength and its relationship with dietary intake from MyHeART Study. All right. So this presentation covers the result of the longitudinal data of the Malaysian Health and Adolescent Longitudinal Research Team, MyHeART, study conducted on adolescent. It indicates that protein intake with physical activity score may influence the male hand grip strength and the multi-ethnic Malaysian adolescents. However, the inverse relationship between energy intake and hand grip strength was found among female adolescents. The result also indicates a structured, tailored intervention should be planned to improve adolescents' overall muscular health. And with us presenting this topic is Dr. Ng Ai Kha. Dr. Ng Ai Kha is basically a new member of the faculty in FOM and also coming from Department of Social and Preventive Medicine. So we'd like to welcome Dr. Ng Ai Kha to the faculty and to the Malaya. She has just arrived last week, and we were able to actually, she kindly agreed to speak to us and introduce herself to the rest of the faculty today. So Dr. Ng Ai Kha graduated with her Bachelor of Science Honours in Dietetics from UKM, Malaysia, and then continued to do her Masters of Science in Public Health in the International Medical University. And for her PhD, she came to Universiti Malaya. So she's currently the senior lecturer in social and preventive medicine, Faculty of Medicine in Malaya. She has 14 years working experience in the field of nutrition and dietetics and food service. She has a clinical and food service dietitian before joining the academia for the past 11 years. Prior to joining UM, she was the program director, clinical coordinator, and lecturer, Nutrition and Dietetics Division, International Medical University. Her research focus is in the area of dietetics, food service, food safety, quality assurance, adolescents' health, nutrition. She's also actively involved in Malaysian Dietetics Association, or MDA, and served as the current honorary treasurer of MDA. And just to add, Dr. Ng Ai Kha also will be joining our team, Jabatan Kesihatan Awam, in PPUM, looking at diet and also food safety. So without further ado, I would like to invite Dr. Ng Ai Kha to start off her session. Dr. Ng Ai Kha.
Thank you very much, Prof. Victor, for your kind introductions. Let me share my screen first. A very pleasant morning to everyone. I'm Dr. Ng Ai Kha, as what Prof. Victor already introduced me, and today I'm about to share my PhD finding from the MyHeART studies, and the title as shown in the slides above. So for the next 20 minutes of my presentations, I will cover briefly in terms of the introductions of the study, includes the objective, followed by the method used, and subsequently we will talk about the results and discussions, and finally what we can conclude from this study and the clinical and its clinical relevance for the audience. So without any further ado, I would like to begin with introductions. To begin with, I would like to ask questions. Why poor muscle strength is a problem? So we know that low muscle strength does impact human health, and this has been well documented in adulthood and also elderly population. And today, more and more evidences have shown that muscle strength is a health marker for adolescents. Studies from cross-sectional and longitudinal have found that having poor muscle strength is associated with poorer metabolic profile, obesity, premature death from any cause, and cardiovascular disease and suicide. And in fact, a cross-sectional study also have shown that, which is from Brazil, shows that the prevalence of poor muscle strength among adolescents is as high as 47%. It's almost, 1 out of 2 adolescents. So what is more alarming is the trend of muscle strength in adolescents at different countries was suggesting a declining trend over the time. Furthermore, a longitudinal study has also shown that low muscle strength in adolescents persists into the adulthood. So, why it is concern for a Malaysian? Over here, I would like to highlight 2 things. Okay, first and foremost, Malaysia is facing challenges that arises from increasing prevalence of diet-related chronic disease such as cardiovascular. In fact, we know that heart disease are the leading cause of deaths in Malaysia. Not only that, we also observe the upward trends of prevalence of overweight and obese among adolescents in Malaysia. And secondly, based on the finding from pure study, it was also indicated that Malaysian adults generally have lower muscle strength as compared to other counterparts from other countries. So based on the earlier slide, I did mention that muscle strength is the health marker for adolescents. Hence, we have the reason to believe that it is important to have a good muscle strength since young in order to prevent non-communicable disease, especially cardiovascular disease. Therefore, this leads to the conceptuals of this research study. So, as we know, over the time, one can lose his or her muscle mass and strength physiologically. But we must not forget there are also other factors that affecting the muscle strength, particularly health-related behavior, such as dietary intakes, physical inactivity, in which these 2 are the interests of my studies. So this leads to the general objective of the study, which is to examining the relationship between the muscle strength and dietary intake variable over 5-year periods in adolescents from the age of 13 to the age of 17 years old, with 4 specific objectives as per outlined in these slides. Next is the methodology that I used. As you can see from this slide, the study design was a prospective cohort study, and the study area is within Kuala Lumpur, Selangor, and Perak, and it was conducted between 2012 to 2016, and we used cluster multi-stage sampling study, and our study populations is a secondary school going adolescent who had participated in all 3 waves of the MyHeART studies. So, of course, this study have received the approval from the Ethics Committee, UMMC, and also supported by the fund from Research Program as well as Postgrad Research Fund. Okay, this slide basically just to illustrate my study as compared to the main MyHeART study. And this slide actually is to show the 3 key study instruments that I used. First is the hand grip strength. Why hand grip strength is because it's a better reflection of total body muscle strength in the adolescent, and also is considered valid, reliable, and feasible for school setting. Next is the 7-day diet history. We use this to assess the dietary intakes. This is because adolescents can recall better and will be able to review more about their intakes, and of course from the epidemiological perspective, less variations in dietary assessment. And thirdly, we use PAC, is a validated tool to measure the physical activity level among adolescents. And of course, we also use the self-administered questionnaire to collect the social demographic information. So after the data cleaning was performed, only 436 participants were used for the analysis of change in muscle strength from 2012 to 2016. An analysis was performed separately according to gender. And this diagram summarizes the data analysis used. Okay, moving on is the results and discussion sections. So in these sections, I will start off with the social demographic and also baseline characteristic of my study populations, followed by 4 key findings that I wish to share with you all today. So out of the 436 participants, 30% were male and 70% were female. The study population was predominantly Malay, followed by Indian, Chinese, and others, and most of them were residing in rural areas. And this table is to summarize the baseline characteristics of my study populations. Okay, so the first findings that I wish to share is about the trend of muscle strength over the 5-year periods. And as you can see, for male, there is a significant increase from 2012, from the age of 13 up to 17. And as for female, we only see there is a changes between 13 to 15. And we also can see that male have increased the muscle strength more than the female. When the hangry strength was expressed in the form of kilogram per body weight, which we call it as normalized hand grip strength, there was a significant changes for male between 13 to 15, but we do not observe, the subsequent age, which is 17, and for female, we do not observe any significant changes. So that was the first finding. The second finding is to describe the trend in dietary intake. We are looking at energy, protein, carbohydrate, fats, and calcium. So what can I summarize from these busy slides is basically male consume more than female. And the trend for both genders shows that the dietary habits are established once they reach middle adolescent, which is 15 years old. So the next key finding is looking at the association between dietary intake, physical activity, and muscle strength when they are at the age of 13 years old. So the blue color representing males and red is representing females. So from here, you can see clearly that physical activity score was significantly predict the muscle strength for male, while none of the variable interests were found to be statistically predict the muscle strength for female when they are at the age of 13 years old. So although there is evidence to show that protein does help protein muscle synthesis and eventually improves the muscle strength, however, the effect of the protein in this study was not seen, neither for male or female. So there could be due to few reasons. The first is maybe because of specific macronutrients such as carbohydrate may play a much more important role than protein or physical activity in muscle strength. The possible explanation for this is that the higher carbohydrate intakes may result in hyperinsulinemia, which in turn enhance the rate of muscle protein synthesis. So it means, in other words of saying that you have to eat enough of and the right carbohydrates in order to have the protein effects to help the protein synthesis and eventually muscle strength. And secondly, it also could be due to protein quality. Based on the empirical study, it has shown that at least 25 grams of high quality protein, which includes at least 8 to 10 grams of essential amino acid and higher leucine content, promote muscle protein synthesis and eventually a better muscle strength. And thirdly, there could be also there are studies also reported that total energy play as moderator role in muscle strength. So that is the discussions from the third key findings. The next is the fourth key findings, which is looking at the longitudinal association between the dietary intake, physical activity, and muscle strength for adolescents when they are 13, 15, and 17. So from these slides, actually none of the variable of interest is associated with the mean differences of hand grip strength. But I would like to highlight two things, which is the protein intakes and also physical activity score, which I box it in green color. You can see that the p-value for both variables suggests that there may be a trend, as these values were almost significant. So as for female, the energy intakes changes was found to be statistically significant, correlated with mean differences in muscle strength when they are 13 and 15 years old. Although the magnitude is was small, the effect may accumulate over the time and become clinically significant if high intake persists for multiple years. So therefore, I think we should not be ignoring this fact. So just to talk a little bit about the male side, the longitudinal analysis indicated that the increment of protein intake may improve muscle strength. So we need to look into that. And on the other hand, surprisingly, the analysis suggested that the increased physical activity may reduce muscle strength. So it's quite contrary to the hypothesis that increased physical activity actually will help to improve the muscle synthesis and eventually muscle strength. So the possible explanation for such a finding, it could be due to the type of physical activity that our adolescent involved in. So if we look through based on the literature, the top three physical activity that Malaysian adolescents are involved in are badminton, football, and cycling. And we know that these activities are not muscle building activity. So this further emphasizes that an increase in physical activity is not enough to increase the muscle strength as per se. As for female, given the fact that these populations, females of the study, gain more body weight compositions over the 5-year periods under the study, especially early and middle adolescent, that's mean 13 and 15 years old, coupled with high intakes, energy intake, this leads to obesity and thus lower the muscle strength. So before I conclude my presentations today, of course, I would like to share a bit of my strength, the strength of my studies. Looking at it is a longitudinal design which allowed the investigation of longitudinal relationship. We also use standardized measurement for muscle strength, energy intake, anthropometry, and physical activity. And it's also a first cohort study in Malaysia as well as in the Asia region that look into muscle strength and diet. So of course, every study will have their own limitations. This study may not fully representing Malaysian adolescent, but it captures a good overview among the study population, and missing data is avoidable due to the study design. Therefore, multiple imputations was used. So here comes to the end of the presentations. What is the take-home message for all of us? I would like to conclude the first message is, we observe that the muscle strength, sorry for the error, the muscle strength actually is increased, but not sufficient. So therefore, we need to ensure the muscle health is at optimal level. And this shows that it is very crucial to identify the prevalence and associated factor of muscle strength among adolescents. The second point is the dietary intakes, looking at the energy, macronutrients, and calcium. We observe that the intake started to establish when they reach 15 years old. So this further emphasizes that we need to intervene. We need to do something before the adolescent reach 15 years old. And of course, the approach has to be tailored accordingly to males and females. The third message is the baseline association shows that only physical activity is associated with muscle strength among males. So with these informations, I think we need to ensure that our adolescents need to be physically active, particularly in female. And this will be a very useful information in development and executions of health education, especially on physical education. And lastly, for longitudinal analysis, the outcome which I have shared just now for males and also female. So with these informations, I think we can use it to promote in the school environment as part of health education to create awareness on the health risks in relations to low level of muscle strength. So in a nutshell, muscle mass and strength in later stage of life are the reflections of the rate of muscle loss and peak attained in the early life. So the efforts to understand the factors that influence muscle strength in adolescents could help to develop strategies that could help to prevent premature mortality and also improve the quality of life at the later stage of life. So hence, this is the time to focus on optimizing nutrition at early stage of life and enhancing muscle strength besides decreasing fat mass and increasing cardiorespiratory fitness. And we have the reasons to believe that this is more likely effective with children's days of nutrition that we need to do. So before I come to the end, I would like to share that actually we have shared these findings through manuscripts or presentation and poster presentations at Hong Kong, Poland, Singapore, as well as local. And before I come to the end, I would like to bring you to the attention of this study, MyHeART, which is the intervention phase of MyHeART study. So the recent intervention study of this MyHeART shows a promising outcome if we want to subsidize fruits and vegetables to make things healthier. So, of course, we need a larger scales of intervention study to confirm the outcome. So, with this, I would like to acknowledge the support of many people for this project, especially both my awesome PhD supervisor, Prof. Hazrin, and also Prof. Noran, and as well as the MyHeART study groups. And with this, I end my presentations with the thank you notes, and I will be happy to answer questions. Thank you very much.
Okay, thank you, Dr. Amaika, for interesting presentation. I think it's quite interesting because there are quite a lot of people actually looking at it, and I think it is very pertinent because we all of us have children and also all of us looking at it. What is the outcome of the activities or the changes in the education system that we have? And we have a lot of debate on education system in the past couple of days, and people are not allowed to comment on how we teach our children. I think that is really something that we need to consider. So from your perspective, all right, let me start with one question that I think we have a lot of time. So let me start with one question that I want to ask you. And you did mention that physical activities is important. How much of physical activity changes have you observed over the time from your time until now, since you are in contact with the MyHeART study? And are we overloading our students? Are we not allowing our children to actually have the physical activities that actually allow them to become healthy adults?
Okay, thank you very much, Prof. Richter, for the questions. So in terms of the physical activities at the schools, I believe that in the school they have a certain structure. So as far as I can know is in a week time, there are twice in a day, but for an hour. So that is that much of activity. And of course, there are certain extra curriculum that after school they will also be involved, but not all the students will be involved as well, because nowadays students are also academically inclined, so they have a class tambahan and so on and so forth. So that's also indirectly taken the time away from them for them to to be physically active. And not to mention, nowadays we have laptops, tablets, games, and they spend more time on this kind of activity. So I would say that they are not spending enough time. Most of them are not spending enough time to work on the physical activity.
Okay, so you think that our education system is failing us?
I'm not saying that failing us, but I would say that, it needs to be improved and look into it, and it can be beefed up, because I think they are looking into how to improve it further. And also through the health education, I think some of it already built into the curriculum as well to create the awareness and so on and so forth. Yeah.
Okay, so let us move on. Basically, I think there's anonymous asking basically, how do you actually ensure that your participant actually report dietary and physical activity daily? How do you promote that?
Actually, prior to collecting the dietary and also the physical activity, the students also will be briefed on, how to answer that. And when they report it on that day itself, we also have the research assistant, including myself, to be there to collect their dietary record. So if they are not able to answer, then we also, able to assist them by asking. So actually, mainly we are doing interview rather than self-administer. Self-administer is more towards the social demographic information.
Okay, good. So there's no way that you're not basically you're not doing anything extra to actually make sure that they report the activities correctly. Besides, so how do you know that the information you collected is valid actually? That's the question.
For dietary intake, actually, we will calculate, what's the term called already? We are looking at whether their intake. We check the impossible energy intake. So if it's very unusual high or unusual low, we will exclude that from the data. That's where I'm doing the data cleaning. So anything that unusual data, it will not be included in the analysis, just to make sure that the information is valid.
Okay. When you say unusual, what do you mean by unusual?
Let's say,
two standard deviation, or how do you statistically?
No, we are looking at the cutoff. We are looking at the cutoff point for energy intakes, like for example, for energy intake that less than 500 calories and more than 5,000 calories, we will exclude from the data analysis.
Okay, so those are impossible Impossible to eat more than 5,000 calories a day.
Yes.
All right, especially for adolescent. All right, let us move on to the next question. Basically, Dr. Kamala Kanan actually asked, usually we encounter muscle weakness in elderly patient, term called sarcopenia. I think you know what sarcopenia. Mainly is due to the vitamin D deficiency, lack of sun exposure, and sedentary life, obesity, too much carbohydrates diet, and obesity. What is your view on that?
Thank you very much for the questions, Dr. Kamala. Very valid, and in fact, actually, this is one of the slides that I didn't share just now. From this study, actually, I have put up, what could be the future research studies that we can work on, looking at the longitudinal associations between the vitamin Ds and the muscle strength. Also looking into the types of carbohydrates, because under the carbohydrates there are high sugars, or high in fiber. Does it relate to muscle strength? So these are something that it's not very clear at this point of time, and hopefully it can be conducted to really confirm the relationships.
So is it diet, or is it physical activity? that actually
If
determine
you-
the muscle strength?
If you ask my personal opinions, I think both play important role.
Both play important role. Okay. Last question. You all can still continue having question. Basically, if you want to, the Q&A is still open. You can actually go and just put in your question in the Q&A. All right. So last question from Shireen. Basically, she was looking at, could you be more specific about the correlation between energy intake and muscle in female adolescent? Do you mean that the increase in protein intake was associated with lower degree of muscle strength? Also, what specific activities would you encourage to build muscle strength?
So yeah, for female, actually, we found that the lower there is an inverse relationships in terms of the energy intakes with the differences of muscle strength. Okay, so that's mean the females is having high intakes of energy intakes, because actually in this study population we also found that the body compositions among the female adolescents is high, and coupled with these energy intakes, then it will eventually lead to obesity and also poor muscle strength. And the increase of protein intake was associated with lower degree of muscle strength. So basically, I mean, this is not what I found in the studies. Actually, none of the protein effect in this study was not observed for male and also for female. But based on the literature, if we increase protein intake, it will help to improve the muscle strength, and provided with the right types of physical activity, which is the muscle building activity. Okay, such as, using the dumbbells, all those activity, which actually at school, I think, I don't think there's such, not every school will have such facility having those, gym type to increase the muscle strength.
Okay, so your recommendation is for female to build muscle, and by to build muscle means you need to have use dumbbells and all those Mr. Malaysian kind of activities. But aren't that not female itself?
Not
So,
to the extent. Sorry.
So yeah, not that female itself. So Dr. Kamala actually is looking at how about high intensity muscle exercise.
Yes, I mean, based on the lecture.
High intensity muscle exercise, basically resistance exercise.
Yeah. Based on the literature, it's also found that the high intensity muscle exercise can improve the muscle strength. Unfortunately, in this study, we didn't really go into very details the types of exercise and all those things. We're just only looking at the total overall score of physical activity.
Okay, so it is a questionnaire-based the assessment, so you were not really specific on what type of exercise they do. So it's basically on overall physical activities, and when there's decreased physical activities, it's related to decreased muscle strength, and also the diet also is related to decreased muscle strength. Yeah. So I think there's going to be more things that can be done. You say that you are doing an intervention study. What kind of intervention are you embarking on?
Actually, the interventions, right? If you look at the slide just now that I've shown, share again. Okay, sorry. So basically, there are three arms. The control arm actually is the standard intervention, whereby the food vendors are being guided, will use the healthy canteen guidelines from Ministry of Health. Okay, so they will go by their food that they can sell, their food that they cannot sell, those guidelines they are following. So the intervention one, actually, we are focusing on the training. So training in terms of healthy cooking methods, the national healthy eating policy, nutrition, and we also taught a bit of the change management, how to deal with it so that, they can go about with it. And the second intervention is training plus subsidizations. So the purpose of subsidizations actually is to reduce the calorie intake. So, for food vendors and the canteen operator, we give subsidize if they increase they sell more fruits and vegetables and lower calories of kueh mui. So that is the interventions that we have created for this MyHeART study.
Okay, thank you very much. Thank you for the interesting presentation. And I think we are almost time, 3 more minutes. If there's no more question, I think we have answered all the question. All right, then we can actually close by thanking both Dr. Ng Aika and also Dr. Aida for sharing with us their experience on research and also on activities on how to take care of a patient who is basically emotional. Dr. Aida, I'm quite emotional too. Can help me out how to handle my emotion. Thank you very much. Okay, bye. Have a nice day and all the best to you all.
Okay, thank you very much, Prof. Victor. Thank you,
Dr.
everyone.
Aida, I will see you soon, maybe. Bye.